Hi everybody and happy Saturday. This is just a quick overview highlight of Heent. And just a reminder that we always try to reiterate is just that all your reading assignments that's listed on your modules, exam questions or quiz questions can be taken from any reading assignment, not just from the PowerPoint. So that's why we say take your PowerPoints, align them with your readings, and that will really, that's really the meat of your information. We certainly do try to cover what we feel is pertinent normals and abnormals, but you really are expected to do your reading assignments, okay? So with the Heent, just a few things that are popping out to myself, again, when we're looking at the head. And I talked to a few students this week, and I really want to encourage you, take your physical assessment rubric, the thing that you're going to perform on that week 7, really kind of by body system, look and see what is the normal expectation on that rubric. What are you assessing? And kind of apply that to every body part. So for Heent, with the head, we're looking at, is the head, what is the size, shape, position of the head? We talked about how people can have tremors, or they're having weakness of the neck muscles and their head kind of hangs down or something. So I really think using that assessment rubric and guiding your studies helps. So again, when we're looking along with the head, and we call a normal head normal cephalic, right? We can have large head, hydrocephaly, and we can have small head, microcephaly. Looking at the neck, we talked about, we got the trach, we want it midline. I don't want to see any goiters. We palpate for tenderness. We're looking at that neck with that JVD. We should not see bulging jugular veins. If we do, the causative factor is fluid volume overload or excess fluid volume in the body. You don't need to know how that happens. It's just that you can identify that that's JVD and that the causative factor is fluid volume excess or fluid volume overload. Same thing. All right. We're certainly, again, looking and be very aware when we talk about lymph nodes. Again, you do not need to memorize those, but we did say it's very important because it is typically not a normal to see lymph nodes, and we can have palpable lymph nodes during an infection. We can have palpable lymph nodes if there is a suspicion for malignancy. And we talked a little bit about the differences that would cue you as a nurse being concerned. Palpable lymph nodes that are more related probably from infection are tender and they are mobile. Malignancies concerns would be that the lymph is non-tender and very fixed or hard, okay? And so, again, we're always assessing those different areas, again, for any kind of lymph nodes that we may see. We talked about, again, with the trach and that thyroid, and again, there can be abnormalities of thyroid that can cause that goiter or that enlargement. So we're assessing the neck to see, do we see any kind of enlargement? And the T3 and T4 are the two hormones that will be produced from the thyroid that really regulates how much thyroid hormones should be released and the metabolism of how they work in the cells and so forth. Okay. Remembering too, again, when we talk about some certain body parts, we use the terminology midline, meaning we want to see it right in the middle of that body. We looked at the nose, we looked at the trach. Is that midline? We talk about the uvula. Is that midline? Because any of those shifts, that's a deviation and that's abnormal. We're like, what caused that shift in that body part? Again, when we're doing the neck and we were taught about palpating for the carotid arteries, we said we never palpate the carotid arteries at the same time. That is because you can cut off that blood supply and that patient can have a syncopal episode, which is fainting. So it's lightly, one at a time, that you're going to palpate. Okay. We also went through and we talked a little bit about the dysphagia with a G versus dysphasia with an S. G is for gag and S is for speech, and that's kind of a nice way to be able to remember those two words. Okay. When we're looking at the face, we talked about how we want eyebrows symmetrical, eyelashes are curved up and outward. So again, looking at that assessment, What are those things on that you're looking for? We like white sclera. We don't want to see hemorrhages or jaundice. We don't want drainage from the eyes. Looking at the pupils, are the irises or that color part of the eyes, are they both symmetric? We're looking at those pupils and pearl. Pupils equal round reactive to light, normal size 2 to 6. And that, what is a pupillary response? Well, it's when you shine the pin light into the eye, what are those pupils doing? They should be constricting. And then when you take the light away, they should dilate back to their normal size. And if they're not doing that, then your pupillary response is abnormal. Or if I'm looking and I have one pupil that's at a size 8 and one pupil that's at a size 2, that's an abnormal. And not that you go into the like what happened, but we know that people with brain traumas that could cause cranial nerve damage, something like that, could have those unequal pupils. So again, just knowing that there's a variety of causes, but normal pupillary size should be between 2 and 6. Let's see. We talked about with visual acuity, just like how the patient can see. We talked about how there's some conditions that can dampen peripheral vision. There's some condition that can cause that tunnel vision. We talked about extraocular movements, and an example of that was with that nystagmus. Or when a patient, you're doing those 6 cardinal gaze, right? When you hold your finger or a pen light or whatever, and you ask the patient to hold their head still and just follow the object with their eyes only. And can they do that, or does it reproduce any kind of extraocular movements? Okay. And so if you did reproduce extraocular movements with any kind of, with that 6 cardinal gaze field test, then that's going to relate back to some kind of neurological movement. The nystagmus, that is that rhythmical back and forth with the eyes. There was a little video of the lady that you can watch again, and that is going to come back to, usually, I'll retract is that, well, I'll just say the nystagmus can come back to some kind of injury with the eye muscles or supporting structures. It can also come back to cranial nerve damage, so forth. Okay. There was several eye abnormal pictures that we talked about that you should go back over. We talked about ptosis, which is where the kind of, if you didn't know better, you would think the patient had a stroke. So it's that kind of drooping one unit, which we call unilateral, one side or the other. And then, so going back and talking again about the ptosis, where that upper eyelid will kind of hang over the pupil. They still have, you can still see part of the eye, but again, it's that upper eyelid that's going to hang down a little bit lower. You can see that for people who have had what's called Bell's palsy. You can see that for people that has had a loss of elasticity that can accompany aging, and it goes back again just like cranial nerve damage. We know that the picture where the eyes are crossed, that is called strabismus. We know that a lot of times this can be congenital, born with it, and then can be usually corrected. There was a couple other abnormals that we tend to see more in the elderly, and that is when the eye will hang, I'm going to try to do it down, and you can really see that conjunctival sac, and that was ectropion. And then the other one was if you have an eyelid that's inverted inwards, and it's like you almost don't see those eyelashes. That's entropion, so think of going in. And so just some different causes from that. Again, if it was muscle related, eye structure related, something of that nature. I think the biggest thing, and then we talked about the bug eyes kind, and that was the exophthalmos. And we talk about what are just those people at risk for. Well, absolutely the ones that have the ectropion, entropion, and the exophthalmos, those are folks that are really going to have a lot of eye irritation, can have more prone to eye infection, dry eyes, things like that. With conjunctivitis, we know that that can be related to allergies or viruses. It can be bacteria. So with conjunctivitis, we usually see that redness in the eye. With cataracts, we know that that lens can be opaque, and we said that usually, again, that's a unilateral finding, not a bilateral finding. And what is that patient's vision going to be? It's going to be distorted, right? Typically, we would see for cataracts, the vision could be either blurry or cloudy, which could be a safety concern, especially when driving at nighttime. With the ears, we're just looking again at the symmetry. We're looking at, again, I said a couple structures of the ear you need to know. Is this part here, which is the tragus, and then this whole thing like the auricle of pinna. And so when we, oh, and then also the mastoid process, okay, mastoid, I'm sorry, kind of behind the ear, mastoid, right here. And so when you are palpating a person's ear, especially the tragus, or sometimes just manipulating the auricles, like pulling up, or maybe palpating the mastoid, if there's tenderness or pain, a lot of times that can indicate that there may be an ear infection. And that would be more of an external ear infection, not internal, okay? We're always looking at the ears to see if there's any discharge. So a small amount of cerumen, which is earwax, is normal, but we should not see any clear drainage, no blood drainage, right? Bloody drainage. Okay. We assess also for ears, can patients hear at a conversational level, or is there a need for a hearing aid? With the nose, we talked again, I already mentioned midline. Does that patient have any history of polyps? Can they breathe through each nary okay? Looking upon, we really should not see any drainage. A lot of people suffer from allergies, so usually more of a clear drainage, sneezing or coughing, or not, take that back, more sneezing or runny nose, which is called rhinorrhea. That can be allergy related. That could be viral related. Think about it, like maybe if you have a cold. More concern is if patients who have a thick, maybe purulent, which can be like an abnormal pussy, or discolored discharge, like a green or something of that nature, then we're more concerned that may be infection. So that green, yellow, infection, clear, generally is going to be a viral or allergies. When we look also in the nose, when we're looking to see, can we see like some inflammation in the nose and that mucosal membrane? And if you do see that it looks a little more pale, then we certainly know that that can be an indication for allergies as well. Okay. Okay. Looking inside the mouth, there was a lot of structures we said there. So again, I'm looking to see if the uvula is kind of in the middle or midline. And then also just looking at the teeth, the gums, the buccal mucosa, which is like the inside of the cheeks, and the tongue is all pink and moist. Do I see that thick coating on the tongue, which is thrush? Do I see any white exudates on the back of the throat, which could indicate strep? Do I see any abnormalities of the lips? They should look kind of pink. We talked about lips, if they're really cherry red, that could indicate a carbon monoxide poisoning. Okay. Again, thinking of any abnormal findings within the oral pharynx is just, again, assessing, is this a new finding? Is it something the patient's chronic? If it's new findings, we always want to alert the physician to it. And again, going back to your assessment guide and going, what is it that we say that you're looking for throughout each one of these body parts? Okay. So I think that's pretty much it. I would tell you just to go, again, review your PowerPoint, your notes, and get into your book and read, match up. And other than that, I think you guys should be good to go. So we will see you on Tuesday. And again, we are going to try to do something a little different. We're going to try, again, we will lecture in the morning, 10:30 to 12:30. I will meet you at the school at 2 p.m. You will go to the great room. We will do our quiz first, and then when you're done, you can head on down to the lab and start practicing. And I think that will hopefully maybe eliminate some of the nerves that you have about the quiz while you're trying to practice and knowing that you still have to take the quiz. So we're going to give that a try this week. If it works out better, then we can do it that way each week. If it felt like, you wanted to still do it at the end of lab, we can go back to how we did it last week. All right, guys, have a great weekend.